All right, so we'll move on to our next. So Nate Cleri is a student who joins us from Stony Brook University. He did his undergraduate degree in neuroscience at University of Miami before coming back up to New York, where he grew up on Long Island. So returning home, he's worked with a number of mentors out there, including Charles Mickle and Seema Mafakam. He will be speaking to us this morning about predicting traumatic brain injury outcomes using a posterior dominant rhythm.
All right, let me just share my screen. All right, thank you, Dr. Morgenstern, for the introduction. So this was some work I had taken a research year as the Daniel Egner Research Fellow between my third and fourth years of medical school in the Mafakam Michael Lab. So this was one of the main projects I worked on, titled Predicting Traumatic Brain Injury Outcomes Using a Posterior Dominant Rhythm. We have no conflicts to disclose. So as many of you know, severe traumatic brain injuries are a global issue. They have an enormous societal, family, interpersonal, and economic impact. But predicting recovery after TBIs is difficult. And previous predictive models have recently shown disagreement between the actual and predicted outcomes. This is thought to be a byproduct of advancements in medical and surgical technology and treatment of these diseases, as well as the models being based on patients from several decades ago. So in our lab's previous work, we sort of looked at thalamocortical integrity after traumatic brain injury. And also previous research has shown that in patients after TBIs who get EEG monitoring for non-convulsive seizures, the posterior dominant rhythm, which is an alpha band rhythm in the 8 to 12 hertz range, generally seen in the temporal and occipital posterior leads, can be a marker of thalamocortical integrity after injury, as well as a reliable marker for functional recovery after these injuries. Specifically, you can see an example here where in generally healthy people, the PDR is present on eye closure, and you can see the occipital and temporal leads here, and the PDR appears, and then when the eyes open, it disappears. But previous research has shown that even after mild TBIs, the PDR can disappear and return slowly several days to weeks after injury. So we thought that would be a very good marker to study in terms of predicting functional recovery after TBIs. So overall, the main objective was to develop new techniques to better predict recovery in STBI patients and assess the predictive power of the PDR following severe TBIs. And to do that, we had built a retrospective database of all 633 patients with severe TBIs from the last decade. That was defined as a GCS of 3 to 8 on presentation. We then looked at the 246 patients who underwent EEG monitoring shortly after injury, and then to standardize the sort of clinical status of those patients, we only looked at patients who were still intubated during EEG monitoring. We allowed 30 days for EEG monitoring after injury, but as I'll show you soon, most patients had those EEGs done very soon after injury, about 2 to 4 days after. We then looked for the presence of the PDR on those EEG reports and created 2 final groups, the PDR positive cohort and the PDR negative cohort, which we then compared to distinguish outcomes. So first, we looked at the general presentation of these patients, and between those 2 groups, there was no significant differences in mean BMI, sex, race, ethnicity, or mechanism of injury. Most injuries on like Eastern Long Island are motor vehicle accidents, motorcycle accidents. We have very few violent traumas or gunshot injuries. And then we found no difference in Marshall CT score or other injury metrics, such as the type of hemorrhage, the brain structure damage. So we looked at the pattern of bleeding, whether subarachnoid, subdural. We looked at if there was frontal lobe damage, temporal lobe damage, etc. The differences we found were 4. We found that the PDR positive groups were slightly older and that the PDR, they had a higher mean GCS motor subscore on presentation, and the PDR negative cohort had a higher mean glucose and a higher rate of traumatic subarachnoid hemorrhage. Of note, all four of these findings have been associated with worse TBI outcomes. So it was not necessarily skewed from the beginning. We thought that one group would have done better than the other. And then we looked at predicted outcomes. So two of the most commonly used TBI predictive models are the MRC crash and the impact calculators. So we put each individual patient's data into those calculators and found no significant differences in predicted outcomes between those two cohorts, specifically no difference in predicted survival or functional outcome using the GOSE, the Glasgow Outcome Scale Extended, after injury. So then after showing that there was no difference in predicted outcomes, we wanted to look at the true outcomes. And of note, we found that the PDR positive patients, those who displayed that EEG signature after injury, had significantly increased in-hospital survival, increased recovery of command following, and a higher mean discharge Glasgow Outcome Scale score. We found no difference in length of stay, which was also important between these patients, and no difference in 6-month GOSE between groups. However, unfortunately, we did lose about a quarter of patients to follow-up at that time point. Next, after showing that the PDR positive patients had overall more superior outcomes, we used AutoScore, which is a machine learning program in RStudio, to develop a new predictive model capable of predicting in-hospital survival and recovery of command following. So we inputted the entire data set, and then we chose the binary outcomes that I mentioned, and the program will then rank the variables in terms of predictability of those outcomes. And then it allows the user to actually choose the variables and a score range. So for example, the GCS being 3 to 15, we chose 0 to 100 as our score range. It will then develop an optimal scoring system and weight each variable based on the ones you choose, and then create a clinical scoring model using your parameters. So based on our data set, we identified 7 variables highly predictive of in-hospital survival and recovery of command following. Those were age at injury, BMI, systolic blood pressure, pupil reactivity, glucose, and hemoglobin on presentation, as well as the PDR and EEG. The first 6 variables I mentioned were the topmost 6 predictive variables of both outcomes. And then the PDR on EEG shortly after injury was the 7th and 9th most predictive variables for survival and recovery of command following. So then, similar to other clinical scoring models you're probably used to, you can rate each patient in each category. So for example, if the PDR was present, that would get 18 points for in-hospital survival and 14 points for recovery of command following. And these numbers were not chosen by us. These were assigned by the machine learning program based on the predictive weight of each variable and the categories, the subcategories within each. So then after taking the sum total score, the nice thing about this is that we can predict on an individual patient basis the chance of each outcome. So for example, a patient with a sum total score of 50 would have an approximately 70% chance of in-hospital survival, an approximately 45% chance of recovery of command following. And each of these dots indicates an attainable score. And the graph underneath shows the proportion of our patients in our data set that would have achieved each score. And the nice thing you can see here is obviously we did not have patients who would have gotten each score, but the machine learning extrapolation allowed us to accurately predict the chance of outcome for scores that we didn't actually have patients assigned for. So then looking at the 70% training and 30% testing set, we had relatively high discrimination, sensitivity, and specificity for predicting these outcomes. As you can see here, obviously there's some room for improvement, specifically with the recovery of command following outcome. But of note, there was not a significant drop between the training and testing set, which we thought was important in trying not to overfit our model. And in the future, obviously this was a retrospective study, and this is only internally validated based on the Hosmer-Lemeshow test and within the program itself. So we're hoping to externally validate this in outside sets in collaboration with other universities. And we're also hoping to sort of proactively use this in patient care and sort of predict alongside their patient's care so that we can sort of get a more proactive data set. So in conclusion, we found that predicting severe traumatic brain injuries based on initial findings often underpredicts favorable outcomes. One of the advantages to sort of adding that PDR on EEG shortly after injury is that you get patients with all the presentation variables, so age, BMI, systolic blood pressure at injury. That's sort of the worst time for them. It's right after their injury, but if you take that EEG finding a few days after, you've had time for things to sort of settle out, treatment to be initiated, and you sort of add that second dimension, and you're not necessarily seeing patients at their worst. We then found that the accuracy using the machine learning model that we created was highly accurate in predicting in-hospital survival and recovery of command following. And we hope to, again, further this research in the future with external validation. So if you're interested in reading more, we were fortunate enough to have this published recently. And I put a QR code here for anybody who wanted to look it up. And additionally, I'm happy to send the PDF to anybody who's interested. So I just want to finish by thanking my mentors, Dr. Seema Mafakam and Dr. Charles Michael in the Department of Neurosurgery, as well as my co-authors on the paper. And again, I want to finish by mentioning and thanking the Mount Sinai Department of Neurosurgery for a phenomenal month here. It's been a tremendous opportunity, and I can't thank you all enough. So I'd be open to questions now.
Thanks, Nate. Dan, go ahead.
So I have a couple of questions. How do you know that you're measuring thalamocortical integrity from just EEG if you don't have any electrophysiology data from the thalamus? And then the second question is, how do you think that PDR differs from other measures of EEG activities, right? So auditory scream and clap, and see if there's reactivity from that. Did you test any other measures of EEG reactivity other than PDR, or how do you think those would compare?
So to answer your first question, the previous research that sort of led us to this hypothesis actually coupled cortical electrodes as well as thalamic depth electrodes. And the thalamic depth electrode trial we still have ongoing. So it's sort of, kind of ongoing research right now, but we also coupled that with scalp electrodes and sort of showed that in patients with more like reactivity for the generalized cortical scalp electrodes, the PDR was generally present. And we also had intact sort of thalamocortical signaling looking at the depth electrodes. And then to answer your second question, we only looked for this study, we only looked at the PDR, but other data we collected, we're looking at power spectral analysis to look at sort of the percentage of alpha, beta, gamma, or delta reactivity, and sort of use those more specific and quantitative measures to assess functional outcome after patients. We used recovery of command following, which you guys are, very familiar with as our functional metric, and the GOSE, because, it's one thing to obviously survive these injuries, which can be very devastating, but then you really want to look at the quality of life after, and command following, being able to take care of yourself or, perform your ADLs in your home after these injuries is obviously another important step. So then, that's why we sort of looked at that.
Thanks, Nate. Do we have any other questions? All right, thank you. We'll move on to our next. So Manhal Siddiqui is a student from University of Buffalo. She did her undergraduate degree there as well in biomedical sciences and psychology. She has been exploring neurosurgery since the beginning of medical school and has been mentored by Dr. Levy and Dr. Siddiqui at Buffalo. She will be presenting to us today on factors associated with shunt-dependent hydrocephalus in aneurysmal subarachnoid hemorrhage.
Thank you for that introduction, Dr. Morgenstern. Just one more. Perfect. Okay, I'm just going to share my screen. Okay. Sorry, I'm just having a little bit of a technical difficulty here. Can you see my screen? Yes, okay, perfect. All right, thank you again, Dr. Morgenstern, for that introduction. As mentioned, my name is Wenhall. I'm one of the visiting sub-Is originally from Buffalo, and today I'm going to be presenting the results of our systematic review and meta-analysis on pre and post-treatment factors associated with shunt-dependent hydrocephalus after aneurysmal subarachnoid hemorrhage. This was one of my independently led studies throughout my second and third year, and it was a very great experience from start to end. So just a couple quick disclosures from our attendings as follows. And then as a brief outline, I'm going to be going into the background a little bit on subarachnoid hemorrhage, the overall objective of our study, our methods and results, and a brief discussion of our findings. So just to set the stage, as we know, subarachnoid hemorrhage can be subdivided into traumatic versus non-traumatic. However, our study primarily focused on non-traumatic subarachnoid hemorrhages. As we know, subarachnoid hemorrhage is associated with a high mortality rate as well as a high long-term morbidity rate. Therefore, having an idea of what factors can lead to these long-term sequelae is an essential part of clinical management in these patients. The pathophysiology that we talk about with hydrocephalus and subarachnoid hemorrhage is that the presence of blood products can cause inflammation and scarring of the arachnoid villi, resulting in both obstructive and absorptive issues. This is likely secondary to the hemosiderin buildup and blood breakdown products. This combined with the decreased overall absorption in the granulations promotes the idea that this overall process is probably what leads to the development of shunt-dependent hydrocephalus. Hydrocephalus management, as we know, involves multiple strategies depending on the timing or length of presentation. Acute hydrocephalus is typically managed with EVDs. However, when this is not effective, we tend to switch to a more permanent version of CSF diversion in the subacute and chronic stages. Typically, we use VP shunts, but this approach is associated with its own set of potential complications. There was a study done in 2017 at Cornell and Columbia that showed from a 17,000 patient cohort, about 24% of patients developed at least one VP shunt complication within the first year, and 22% required a shunt revision at some point. These statistics just truly reinforce the need for careful monitoring and follow-up to minimize these complications and optimize outcomes. So for our objective, we found that in the literature, there are many various reports of risk factors associated with shunt dependency in these patients. However, the presentation has often been fragmented and heterogeneous. So our objective was to conduct a systematic review and meta-analysis to provide a more comprehensive analysis of these prognosticators and further build our knowledge base for clinical decision-making. So for our methods, we followed the standard PRISMA guidelines. We searched for studies in PubMed, Embase, and Medline. We looked at studies from inception to November 1st, 2022, and to ensure any accuracy, we had a two-party independent review and had a third party to resolve any discrepancies. For our inclusion criteria, we specifically defined shunt dependency as the presence of acute hydrocephalus that failed to resolve with temporary CSF diversion, or alternatively, hydrocephalus that developed in the subacute to chronic periods requiring shunting. We also limited our analysis to double-arm studies that compared these shunt-dependent patients to a distinct non-shunt dependency cohort. Initially, we identified about 1,700 articles. After we excluded ineligible articles, we secondarily assessed 70 for eligibility, and using our inclusion criteria, we selected 37 review studies for overall review. We used a meta-analysis for each collected variable and a fixed and random effects model, which was weighted for sample size for each study. And this was used to generate the estimated rates for each variable of interest. And just a quick look at our characteristics, we had about almost 13,000 patients over the 37 articles. We had 29 retrospective studies, 3 RCTs, and 5 prospective studies. We had a cohort of 2,200 patients with shunt dependency, and about 33% of these patients were male. So complementary to previous literature, we found that the variables on the left side of the screen were consistent with previous studies. Again, this had been noted amongst variable studies, but we found that the variables reported on the right were more fragmented. So we looked at high World Federation of Neurosurgeons score, granular vessel involvement, delayed cerebral ischemia, intracerebral hematoma and decompressive hemicraniectomy. Over the next couple of slides, I'm just going to very briefly go over our results and a short discussion for each of these variables on the right. So for each variable, we've shown forest plots demonstrating the odds ratios. So starting off with the WFNS scale, for a score of 1 to 3, odds ratio is less than 1, and the significant interval did not cross over 1, which indicated that there was a statistically significantly lower likelihood that these patients will develop shunt dependency. In other words, a low WFNS score essentially was a protective factor. However, in contrast, a high WFNS score had a high odds ratio, or an odds ratio of 2.41, which indicated that these grades have a higher likelihood of shunt dependency. So the WFNS scale was introduced in 1988, about 2 decades after the Hunt-Hess score. However, contrary to Hunt, Hess, and Fisher, the WFNS score is based off of the GCS scale and the presence of focal deficits to determine the severity and predict outcomes of subarachnoid hemorrhage. In contrast, as we know, Hunt-Hess relies on clinical presentation, which is later translated into GCS, and then Fisher relies on radiographic presentation. So alongside establishing the significance of this scale, our study also corroborated the previous literature. However, subsequent studies have also shown that GCS-based scoring systems are superior to Hunt, Hess, and Fisher grades, given the objective way of defining the neurological condition. Every neurosurgeon is very well versed with GCS, and the inter and intra observer reliability is considered relatively strong. And then added to this was the element of focal deficits that made it a complete scale. So while the WFNS scale does have its own flaws necessitating modification, our studies show that it still may be stronger utilized as a potential marker in these patients who develop shunt dependency or are prone to develop shunt dependency. Next, we looked at aneurysm origin. Previous papers primarily focused on anterior versus posterior circulation aneurysms as their dividing factor for location, with posterior circulation consistently having higher odds given the tight anatomy. Our study was consistent with these previous studies. However, we also chose to analyze study that included a very granular breakdown of specific vessel involvement. We were able to further break down location to identify which vessels were at a higher risk, rather than just looking at anterior versus posterior. So what we found was that in both the anterior cerebral artery and the vertebrobasilar arteries, our odds ratios were greater than 1 and significant. In contrast, we found that the middle cerebral artery had an odds ratio of less than 1, indicating that there was a lower likelihood of developing this shunt dependency. We theorize here that this is likely based on which vessels are closer to which cisterns and how kind of the location of them is essentially what is more likely to be involved here. But overall, this kind of just reinforced the idea that granular vessel breakdown allows us to be proactive rather than reactive based on our knowledge of what specific vessels are involved. Next, we looked at decompressive craniectomy in patients who required an intraoperative decompressive hemicranie, and this was significant for an odds ratio of 3.36. Decompressive hemicranies are a well-established practice that lowers the elevated ICP in patients with a refractory increase in pressure following trauma or infarct. However, previous literature has noted that the evidence for aggressive surgical interventions is controversial in poor clinical grade patients. Our analysis did find that the likelihood of SCH or shunt dependency was higher in these patients. We theorize that, as we know, the removal of the skull dampens the normal vascular pulsatility in the Virchow-Robin space, which drives the bulk of our CSF flow. And this can result in a buildup of CSF and subsequent pressure. We hypothesize that this disruption of equilibrium is likely what interferes with the ependymal cell's ability to reestablish equilibrium. However, we did feel that we would need further, more basic science studies to try and confirm this theory. Next, we looked at delayed cerebral ischemia, again, significant with an odds ratio of 1.61. This is a critically preventable cause of poor neurological outcome and mortality, which affects about 30% of subarachnoid hemorrhage patients. A majority of the patients who develop DCI are left with significant motor deficits, cognitive dysfunction, and an overall reduced quality of life. DCI prevention has been the crux of many subarachnoid hemorrhage studies, but as of now, there are few treatment options available. Again, just reinforcing early recognition and detection being the key for timely intervention. And then finally, we looked at intracerebral hematoma. Again, had a odds ratio of 3.23, which was significant. Patients with additional post-op ICH are also described as being poor admission grade and historically also having unfavorable outcomes. Amongst the different literature, intracerebral hemorrhage secondary to subarachnoid hemorrhage varies from 4 to 43%. However, overall, the agreement is that this is a very negative prognostic factor associated with very high mortality rates greater than 80%. Again, this finding just reiterates the need for critical early recognition and detection and timely interventions. So as a systematic review, we did have some inherent limitations to our study. There is publication bias amongst these type of studies overall, especially because they're observational retrospective studies. As a result, we had very diverse patient populations amongst each study, and this resulted in a very heterogeneous representation of what risk factors were presented by each paper. As a result, we did have to exclude some variables that may have been very clinically significant, but were not statistically significant or analyzable. And we ended up cutting out some variables that were, again, very clinically significant, but we try to focus on having very granular data points to allow for more rigorous analysis, even at the cost of excluding related but unspecific data. For future directions, we kind of split it up into clinical impact and research impacts that we're hoping to make. Clinically, again, early detection, early recognition, and would allow us to help with improving communication and expectations to both patients and families, and managing expected lengths of stay and in-hospital protocols. In terms of research, we're actually trying to work on getting a buffalo population case series started with our subarachnoid hemorrhage population. Also, another idea that we were hoping to look at is looking at how these different risk factors play a part at different parts of this, our timeframes in hydrocephalus, in acute versus subacute versus chronic. This was just not, there was not enough granular data available for this. And then we're also hoping to go forward from here to build a model for shunt dependence, and then derive a simpler, more calculator-based tool based on our practice. Ideally, we would like to, at some point, externally validate this. We're working on getting this started with our med student team. And then at my last sub, I had a discussion with one of the attendings there about including a risk model calculator based on each prognosticator, which has been something that I've been thinking about and trying to get more input on. So these are just my references. And just really quickly, I want to acknowledge the team back in Buffalo, Dr. Levy, Dr. Speaky, Dr. Lim, who's been one of my mentors, and Dr. Montiero, as well as the rest of the endovascular research team. They've been a great set of support. And then I wanted to say a quick thank you to everybody here at Mount Sinai for hosting me this month and for allowing me to get to know your team and your service. I've had a fantastic time, and I'm really sad to be leaving this weekend. So thank you very much for your time. I'm open to questions.
Thanks a lot, Manhal. Great presentation. Obviously, this is a topic that is very pertinent to my practice. Were you able to look at spinal drainage or use of spinal drainage?
So there was 1 or 2 studies that did touch on it, but again, they were studies that just didn't have enough patients, or just we didn't have enough studies to do a proper analysis of it. So lumbar drainage was something we looked at. We even looked at clipping versus coiling to see if that had any impact, as like if treatment modality had any impact on our outcomes. There wasn't enough granular data. So I think that is also another thing we're hoping to look at when we do our case series.
All right, thank you, Dr. Keller, for the introduction. So I'm Sam, I'm a fourth-year medical student from the University of Rochester, and today I'm going to talk about some research that I did in the program for translational brain mapping. I started working in the program for translational brain mapping as an undergrad at the University of Rochester, and continued working, before med school and then throughout med school as well. A key part of this research is mapping cognitive functioning in patients who undergo neurosurgical interventions. And there are 2 main goals of this research. One of them is to use the tools of cognitive neuroscience to advance personalized neuromedicine in the form of brain maps, and then also to use the clinical preparation of neurosurgical patients to test mechanistic hypotheses regarding how cognitive functions, the models of cognitive functioning in these patients that are undergoing surgery. So I want to talk about foundational tenet that underlies much of the research that we do, and the activities that we perform in the program for translational brain mapping, and then also about our method for how we study cognitive functioning in these patients in the operating room. So the foundational tenet I'm going to talk about is the oncofunctional balance. So the oncofunctional balance is that neurosurgical interventions to remove brain tumors or treat medically refractory epilepsy have to balance removing as much of the pathological tissue as possible against removing the tissue that incurs the risk of causing a new neurocognitive deficit in a patient, in the form of a sensory, cognitive, or motor deficit. And this relationship, as it pertains to brain tumors specifically, is referred to as the oncofunctional balance, but a similar relationship occurs in any neurosurgical intervention, really. So on the onco side of this balance, surgery is a mainstay in the treatment of both high and low-grade gliomas, and extensive resection is an important treatment-related predictor of survival. And while suggested extensive resection cutoffs need to see these survival benefits with greater extensive resections have varied over time and across studies, it's generally accepted that the maximal safe resection remains a goal of surgery for high-grade tumors. And in a systematic review and meta-analysis, they just demonstrate that there's a statistically significant difference in survival at both 1 and 2 year time points when comparing gross total and subtotal resection, favoring with increased survival in gross total resection. And then a similar trend is also seen in low-grade gliomas as well, with the decreased hazard ratio with greater total removal. So on the functional side, new neurocognitive deficit is understandably associated with a decreased quality of life. This is a study of 88 patients with gliomas from a single center who completed a quality of life assessment at pre and post-operative time points, and they demonstrated a new motor or sensory deficits or new ataxia or unsteadiness were significantly associated with decreased quality of life. And that's pretty intuitive. But what's perhaps less intuitive is the finding that a new post-operative deficit can be correlated with increased mortality. And so this is a single center retrospective review of all patients who had undergone resection for a GBM over a 10-year period. And they compared the survival in patients that had experienced surgically acquired motor or language deficits versus those who did not acquire any new deficits after resection. And what they saw was that the patients with new deficits had a significantly decreased median survival when compared to patients without new deficits after surgery. And while the difference was on the magnitude of about 3 to 4 months, that represents a pretty significant 30–40% difference. And in another study, that's a single center retrospective review study of 115 patients with GBMs that again demonstrated that increased extensive resection was significantly associated with improved survival. And this was seen for across different tumor volumes, wasn't seen in the tumor volumes less than 15 cubic centimeters, but that had to do with the factor of percent of residual tumor volume. But more interesting in this paper is their analysis that's depicted in this graph, where they predicted overall survival by extensive resection and presence of a new postoperative neurological deficit. So patients with an extensive resection greater than 95% with postoperative neurologic deficit had a very similar survival as patients who had an extensive resection less than 95% without a postoperative neurologic deficit. So looking at the green and blue lines here, you can see that the survival benefit afforded by increased extensive resection was erased when a new deficit was present. So the oncofunctional balance becomes a little more complex when considering that extensive resection is not the only thing that affects mortality or confers a survival benefit. And to further add to the complexity here and the relationship between brain tumors and neurocognitive functioning, the brain tumor biology has been demonstrated to be associated with neurocognitive functioning. And so in this study of 119 patients with malignant gliomas prior to surgical resection, they see that looking at neurocognitive function, they see that IDH wild type versus mutant tumors They found that neurocognitive function impairment was significantly more frequent in patients with IDH wild type tumors, in the domains of memory, process and feed, visual construction, language, executive functioning. And so the oncofunctional balance is complicated. And it becomes even more complicated when you consider the evidence that, impacts of tumor biology on neurocognitive function, and also the, potential survival benefits of, or increased mortality with new acquired iatrogenic deficits. So what we do know is that neurocognitive function is important for survival, and then we also need to better understand neurocognitive functioning in these patients. So now I want to talk about a little bit how we do that, specifically in the program for translational brain mapping at the U of R. And so I'm going to go through some illustrative cases, which are all part of an ongoing prospective longitudinal study evaluating preoperative fMRI, DTI, and intraoperative direct electrical stimulation mapping for delineating maximal safe resection, to discuss how we study neurocognitive function in our patients. So our standard protocol, we study patients at 3 pretty basic time points: preoperatively, intraoperatively, and then postoperatively as well. And we do this, using a few different methods. So we do a standard neuropsychological test battery that we do in our lab. This consists of tests on the computer or paper tests, or even pantomime. We also do fMRI experiments, so we do BOLD, DTI, and we test a bunch of different neurocognitive domains as well. And the tests that we do beyond just the standard battery that we have are tailored based on either the lesion location and the predicted, potential deficits or substrates involved, or that could be involved in the resection. But then also based on patient-specific factors. For example, if a patient is a accountant, it's understandable to think that their knowledge of Arabic digits or their ability to do arithmetic might be very important to them. So those are things that we might look at in an fMRI experiment, or even with direct electrical stimulation mapping in the operating room. And so here's just a kind of sample of our battery, and you can see all the different tests and different domains that we can test here. If you look at the right hand of the screen, you can see a bunch of the different fMRI experiments that we can do, testing language, verbal fluency, music, motor localization, somatosensory localization as well, and a bunch of different language domains. And then this is a schematic of what our mapping setup in the operating room looks like. So basically we have a setup involves a monitor that faces the patient. It goes under a drape, and that drape is held up by an ether screen. And we have a microphone and camera that's pointed and directed at the patient's face, so that we can both record the responses of the patient for analysis after surgery, but then also so we can connect it to different screens within the OR, so that the surgeon and everybody else in the room can monitor the patient's responses, be it a facial twitch, or just seeing the patient speaking and conversing. And then also we connect that to our language mapping computer, and we have the stimulus presentation, exactly what the patient is seeing, presented on a screen in the operating room as well. We temporally correlate the stimulation with electrocardiography, and we also register the bipolar stimulator on the cranial navigation. In our case, we use BrainLab, so we use the registration star, and so we can collect the coordinates of stimulation in 3D space and correlate those with the trials and the responses. And so that's really, mapping allows for us to get a huge data set, and we get to collect that and do further analyses outside the operating room. And so this is what it looks like, kind of in the OR, not on a schematic. So you can see the registration star on the bipolar stimulator. You can see on the screen, in the top right-hand corner is the patient's face. Right below that is the stimulus that the patient's seeing. Normally it's full screen, but the patient isn't seeing the video feed of their face. They're just seeing that white box in the bottom. And so this is a video. I'm not sure it's going to let me play it over Zoom, but I've included the link down below, and I can also email that out, just demonstrating some of our language mapping in the operating room. And here's just a still of the video, so you can see kind of in the top left of the screen, the patient's face. So this is what the surgeon and everybody else in the OR can see. This is a picture of the stimulation right under that of what the patient is seeing. And then also we have the electrocorticography data in the upper left corner. And so I just want to go through an illustrative case, actually 2 illustrative cases, just to demonstrate, our protocol and some key points. So first is a patient with a left superolateral posterior frontal lobe lesion. This is patient AF, and it's a 6-year-old patient with a lesion that had been followed for a number of years. But then, it showed slight interval growth on MRI, and the decision was made to proceed with surgery to the location just anterior to the primary motor cortex and also superior to the inferior frontal gyrus. And so a weight craniotomy was performed. And postoperatively, she actually was found to have a speech deficit with impaired production of fluent speech, but no other language deficits otherwise, no impairment with picture naming or anything like that. And so reconstruction using probabilistic tractography showed that postoperatively, the frontal ascending tract was partially resected. This is a connection between the inferior frontal gyrus and the supplementary motor cortex. And so on the left, here you can see the left frontal ascending tract in light blue. And on the left hand of the screen, you can see the preoperative construction of it. And then on the right, you see the post. And you can see in that third row that, it's partially resected, during her surgery. And so, another patient that was seen, by the neurosurgery department and then later enrolled in our study, presented us an opportunity to study the frontal ascending tract further and test some hypotheses about the role of the frontal ascending tract in sentence blending. So using that experience and seeing that deficit, and then also the reconstruction of the frontal ascending tract, we were able to make hypotheses about the function of the tract, and then also test those hypotheses in patients. So this is patient AI, and 46-year-old male with a left frontal.
About 2 more minutes, Sam.
All right, thank you. Left frontal oligodendroglioma, and it was located just anterior to motor cortex, and with the anterior margin of the tumor was abutting the posterior aspect of the frontal ascending tract at the superior medial end of the tract. And so, this presents us an opportunity to both map the frontal ascending tract in the operating room and test mechanistic hypotheses about the tract's function. So we designed a task that could be used intraoperatively while the frontal ascending tract was stimulated, and that would enable different components of sentence production to be examined. So the patient was presented with a 2x2 square of colored geometric shapes. And on each trial, one was bolded with a thick black outline, and the patient's task was to describe the position of that shape that was bolded in relation to the other shapes on the array. And so, for example, here, the yellow triangle is above the red diamond. And some mechanistic hypotheses that let us test was looking at, was it lexical retrieval? And we can look at the different patterns of responses that we would see in the operating room while we were stimulating the tract to test these hypotheses and draw conclusions. And in short, here's a video. I can also send out the link to that, but of the intraoperative mapping of that patient. And in short, we saw that the frontal ascending tract. We saw that the frontal ascending tract. We saw slow or longer interword durations and no changes in intra-word articulatory durations. So that lets us know that it was part of sentence planning and not lexical retrieval otherwise. And so here's just a picture depicting a bunch of different things that we can map in a patient's brain. And this actually comes from a paper by Dr. Jumper. And, the point I want to make here is that we're pretty good, in the field of neurosurgery. They're pretty good at mapping all these different functions, but at the same time, that presents the opportunity to collect all this data and really learn from each patient. That's not always done. A lot of the times that mapping is completed, it's using, either paper stimulus or something on a phone. And a lot of this data, this really rich data set gets lost. So I just wanted to demonstrate here that, there's a lot that we can learn from each patient, and patients represent a unique opportunity to study function. And neurosurgeons really have that unrivaled opportunity to interact and study the brain in a way that not many other people have. And then you can also apply insights from one patient to treating the next patient in our example of mapping the frontal ascending tract as well. Next steps would be to obviously scale this and make predictive analyses based on intraoperative mapping with real-time predictive abilities. And I just want to say thank you to Dr. Pilcher, who's the clinical chair of the research program, and Dr. Brad Mann, who's the scientific director of the program.
Thanks, Sam. Do we have any questions for Sam? I think we have time for one. All right. Thank you, Sam. That was a nice presentation. It's a tough, it's tough to show a whole mapping paradigm in the amount of time that you have. Each institution does things a little bit differently, and you can appreciate the work that goes into putting together the paradigm and tracking the data related to patients. So I think you made some good points there. We'll move on to our last speaker. We have Brandon Gonzalez. You haven't all met him yet because he started this week. But because of scheduling, we're having him present his talk today. Brandon is a student at the Tillman Fertitta Family College of Medicine at the University of Houston, having completed his undergraduate degree at the University of Texas, Rio Grande Valley in biomedical sciences, followed by an MPH and an MBA, also at the University of Texas School of Public Health in Rio Grande Valley. He is a native of Texas, raised in Brownsville, and he is a member of the first class of the Tillman College of Medicine. He's done quite a bit of research in statistics and epidemiology, and is applying those skills in his neurosurgical research. He'll be presenting today on patterns of failure following gamma knife stereotactic radiosurgery salvage for recurrent high-grade glioma. Welcome, Brandon.
Thank you for having me. Can everybody hear me?
Yes.
Let me go ahead and share my screen. Okay, everybody seeing my slides? Okay, great. So my project is entitled Patterns of Failure Following Gamma Knife Stereotactic Radiosurgery for Salvage for Recurrent High-Grade Glioma. And as mentioned, my name is Brandon Gonzalez. I'm from the University of Houston in Texas. I'm a fourth-year medical student. So I wasn't sure what the format or context of this presentation would be. So just a little bit more about myself. My hometown is Brownsville. That's Elon Musk up there. I thought that was pretty comical. He's eating one of the local foods and one of the yearly festivals we have. Yearly, I like to volunteer in the Science and Engineering Fair of Houston. I serve as a science fair judge there for high school and middle school students. I also started a research club at my school. There's a lot of students interested in research who don't have much experience. So as part of that club, we try to expose them to research and try to get them to network with attendings who might potentially be their residency program directors. During my spare time, I like to exercise. I like to go to wine and cocktail bars. That's the picture on the right. Name of that place is Parkwood. I like to play mini golf. I like to play actual golf too, although I'm not that good at golf. So, and I'd like to start off my presentations by acknowledging just the rest of the research team. This is it here. It's the attendings at UT Health Houston, It is composed of neurosurgeons, neuroradiologists, residents, and radiation oncologists. And I also want to thank the department here of neurosurgery for having me. I don't have a home program, so it's extremely important for me to do these ways. So let's go back to the beginning. I'll fly through this. I'll try to touch on the high points. So the research question is, what are the clinical and demographic factors associated with pattern of failure following salvage, gamma knife, stereotactic radiosurgery for recurrent high-grade glioma? This is more of a background slide for the medical students, just to define what the high-grade gliomas are. Those are the anaplastic astrocytomas, as well as the glioblastomas, and this is a 2016 classification of the World Health Organization, and they're basically separated based on molecular profile. On the right, I had some information on essentially grade 4 gliomas. The median overall survival is about 10 to 15 months, depending on what paper you see, and the 5-year overall survival is about 5%. Standard of care is following the Stoop regimen, which is surgical resection followed by radiation therapy and chemotherapy. However, disease does tend to progress at around 5 to 7 months. So, and then recurrent disease can be treated with gamma knife radiosurgery. This is a paper that came out in 2019, and they were essentially trying to find predictors of failure location, for failure location following salvage gamma knife. And the way they defined failure location was either infield, marginal, distant, or remote. Infield was if the recurrence occurred within the 50% isodose prescription line. Marginal was less than 2 centimeters away, distant 2 to 5 centimeters away, and remote more than 5 centimeters away. And as shown in that little snippet on top, most of the failures, so 40 out of 47 failures occurred infield. So gamma knife was essentially pretty good at controlling disease locally. And because imagining what failure location might be inside of the brain, it could be a little bit abstract when you first think about the concept. So on the left, I have pictures of what infield failure location looks like. That picture labeled as A is the original tumor, and the picture that's labeled as G is the recurrence following gamma knife. So as you can see, it basically came back in the same area, and that's infield. Marginal is in the middle column. So picture A is your original tumor, and picture E is the marginal recurrence. And then on the right, I have the distant failure. So picture A is the original tumor, and picture D is the distant tumor. In that same study, they identified older age as a predictor of more distant pattern of failure. So older patients had more distant and remote failures following salvage gamma knife. And a dose of 18 gray was associated with less distant and remote failures. And there was a significant linear relationship between SRS dose and time to failure. This is another study that came out in 2021, and they essentially wanted to do the same thing as the first study, which was to identify patterns of failure following salvage gamma knife. And as you can see, 24 out of 51 patients failed locally only. And there were some patients that had combined patterns of failure. So about 62% of patients had combined patterns of failure. And on the right, you see the Kaplan-Meier curves comparing infield local recurrence versus other types of failure. And those with infield failure had better overall survival. In their analyses, they really didn't find any demographic nor radiosurgical parameters predicting failure location, except for one tumoral association, which was a 1p19q co-deletion, which was essentially protective. It's characteristic of oligodendrogliomas. So now to get to the analysis that I did, These were 146 patients treated to a total of 412 targets at a single institution between 2008 and May 2020. And what's special about these data are that this is longitudinal data. To my knowledge, this is really the only study that examines multiple recurrences. So the other two studies I mentioned, and as well the ones that are out there that I didn't mention, are cross-sectional, whereas here I did both cross-sectional and longitudinal analyses. So the inclusion criteria were patients were 18 years or older. They had a histologically confirmed diagnosis of either grade 3 or grade 4 high-grade glioma, and they were treated with gamma knife radiosurgery for recurrent high-grade glioma. The analyses I did were Kaplan-Meier survival curves, as well as a variety of different regression methods, which I won't really talk much about. I'm a nerd about that stuff. If anybody has any questions, then certainly ask me at the end, but it essentially was regression. So these are just some of the descriptives. So the median age at gamma knife treatment was 60 years. Most patients were non-Hispanic whites. The median KPS score at gamma knife treatment was 60. The median time to gamma knife treatment was about 12 months. The median dose for which patients were treated was 18 gray, and the range was 10 to 24 gray. So out of 146 patients, 61 patients failed their gamma knife at their first lesion, and most failures, or about 50%, occurred infield, in an infield pattern of recurrence, which was that definition that I used earlier. So these are Kaplan-Meier curves just showing overall survival and progression-free survival for the 146 patients. And this is following gamma knife. So this is not following diagnosis. So following diagnosis, and I actually don't show this here, but following diagnosis, median overall survival is about 26 months, which is substantially better than that shown in the literature. So following gamma knife, median overall survival was about 12.4 months, whereas median progression-free survival was about 8.2 months. So in the analysis of local failure, I used a variety of univariable and multivariable models. Whatever was significant in the univariable model, I then included in the multivariable model. And because we were really interested in analyzing SRS dose, even if it was not significant, although it was significant in the univariable model, I kind of forced it into the multivariable model. So as you can see, older age at gamma knife was offensive. So patients who were 60 years or older had a higher hazard for local failure. Interestingly, patients who were non-white had a lower hazard for local failure. A KPS score of 70 or higher at recurrence was protective as well. And a dose of 20 gray or higher was protective as well. So that was a lower hazard for local failure. So then, because we saw in the literature that essentially age and dose, and as well as in our preliminary analyses, that age and dose were probably variables that are predictive of local failure, I then generated these cumulative incidence curves showing local failure over time, and they're kind of separated based on patient age and dose. So as you can see on the top curve, patients who were older and who were treated with a dose of less than 20 gray had a higher cumulative incidence of failure over time, whereas patients who were treated with a dose of greater than 20 gray and who were younger than 60 years of age had a lower cumulative incidence of failure over time, and that's that green line in the bottom. So now for the analysis of failure location. Really, there were only two variables that were predictive of failure location. So whereas before I mentioned the non-white race was was protective for local failure here, non-white race is actually offensive for a more distant pattern of failure. In the bottom, I show that SRS dose greater than 20 gray was offensive for a more distant pattern of failure in the univariable model. However, it was not predicted in the multivariable model. So just to conclude, the dominant pattern of failure was local. About half of failures occurred in field. Local failure was less incident in younger patients treated with a higher SRS dose. Over time, older age at SRS was associated with a greater hazard for local failure, and non-white race was associated with a more distant pattern of failure. So the major strength of this study, as I mentioned before, is that it's pretty well powered. It's a longitudinal study. So some of the limitations are that I didn't include a molecular analysis in the slides I showed here. Although I did in my analysis include some mutations such as TERT, CDKN2A, CDKN2B. However, sample sizes differed for some of these variables since they were not collected for all patients. So I didn't feel too comfortable including that here and discussing it within the context of this short presentation. But if anybody has questions, I'm happy to answer in a minute. And also, I didn't include any chemotherapeutic or biologic data. Most of these studies include that information, such as whether effect sizes are modified based on biologic use. So for future directions, I would like to include more molecular data, as I mentioned. And because I'm trained in epidemiology, something I was interested in was also in including some of the variables that I listed there. At the bottom, there's some data showing that survival differs based on race, for example. However, that survival might be confounded by some of these variables, such as metabolic syndrome, income, smoking, education level, etc. And these are my references. Anybody has questions, happy to answer.
Thanks, Brendan. Do we have any questions? So I have one. So what was the, how do you account for some of these patterns of failure, particularly the age component that you mentioned, that younger patients tend to fail less often than older ones?
Yeah, that's a very interesting question and something I've certainly thought about. It's difficult to tell you what the most, I guess, correct answer would be, but my thought is that some of these older patients might present with a more advanced disease, or they might have a certain molecular profile that younger patients might not have. And that might also hold true for the associations with race.
Yeah, I think those are good thoughts. I think the other thing to make sure in these kinds of studies is you want to control for the different, you mentioned that you want to incorporate molecular analyses into these. I think controlling for the different diseases that different populations get is really important when you're looking at this. So either just looking at one subpopulation to study, or making sure you stratify them by those important markers of risk.
Absolutely, I agree. And as I said, I did do some analyses. It's just sample sizes differ, and then that would mean that I would have to also analyze whether their descriptive characteristics differ, because I want to make sure that whatever results I do get are not biased.
Great point. Do we have any other questions in our final minutes here?
I have one question. So one thing that I've thought of before, what do you think of this idea in patients that have, high genomic instability? You're applying radiation. Do you think that it's possible that you're driving further mutations that could be associated with worse survival in some subset of tumors? Or do you think that's a reasonable idea, or what are your thoughts?
I think hypothetically that's a very interesting point. Although gamma knife is pretty, or stereotactic radiosurgery is pretty precise in its approach to target lesions. So I would imagine that the answer might be no, but it's a good thought.
Yeah, definitely an important area of study. All right. Well, thank you everyone for attending today, and thanks to all of our sub-Is for joining us and putting in the work this month. You all did a great job, and we're looking forward to hearing from you over the interview season. Thanks, everyone. We'll see you next week.